Okay, good afternoon, everyone. We're going to go ahead and get started. Thank you for coming to Medicine Grand Rounds. It is my distinct pleasure to introduce our Grand Rounds speaker today, Dr. Austin Robinson. Dr. Robinson is Associate Professor with tenure and Director of the Neurovascular Physiology Laboratory at Indiana University. He is a nationally renowned researcher and exercise physiologist whose work centers on navigating the impact of nutrition and physical activity on cardiometabolic health and disease. By way of background, Dr. Robinson obtained his Bachelor's of Science in Kinesiology and Exercise Science in 2010 from the University of Indiana, followed by a Master's and a PhD in Kinesiology, Nutrition, and Rehabilitation from the University of Illinois in Chicago in 2012 and 2016, respectively. At a fairly young stage of his career, Dr. Robinson has had a storied career in research. He's had appointments at Benedictine University, University of Illinois, University of Delaware, most recently Auburn University, where he served as the Director of Neurovascular Physiology. His current research portfolio is supported by multiple NIH grants. His work has been published in journals such as the American Journal of Clinical Nutrition, the Journal of Applied Physiology, and the New England Journal of Medicine. One of the things that Dr. Robinson and I talked about this morning was his strong track record on mentoring students, including PhD students, fellows, and postdocs. He has a dedicated and track record of commitment to diversity, equity, and inclusion. He is the recipient of several pre-doctoral and postdoctoral NIH diversity supplements and co-mentor to 2 NIH RISE T32 fellows. He's also, not surprisingly, the recipient of numerous awards, including the NHLBI Pride Mentee Training Awardee in 2019, Physiology and Pharmacology Ambassador for 2023, and multiple other recognitions. It is a true honor to have him here. Please join me in welcoming Dr. Robinson for Grand Rounds. Thank you.
All right, so thank you, Dr. Chopra, for that introduction, and thank you all for joining either on Zoom or in person. So for today, I'll be talking about balancing the scales, exploring strategies to counteract the negative effects of high sodium diets. And I wanted to open up with a question. So the question is, what can we glean from patients who have salt-sensitive hypertension or salt-sensitive blood pressure? And so for a bit of background, the picture we see here is Dr. Marvin Weinberger. And so in the 70s, 80s, 90s, he was the director of the Hypertension Research Center at the Indiana University School of Medicine. And he developed this protocol that was a 3-day inpatient stay to test salt-sensitive blood pressure. And so on the first day, patients who had hypertension would withhold medication for 2 weeks. And then they would come in overnight. And then the following morning at 8 a.m., they would have their blood pressure measured. So on that second day, from 8 a.m. to 12 p.m., they would undergo a normal saline infusion. So 2 liters of normal saline over the course of 4 hours, so 8 a.m. to 12. And then after that, they would have their blood pressure measured again for a second time. So that initial morning, this would be pre-saline blood pressure, post-saline blood pressure. And then in the subsequent day, they would receive a very low sodium diet. So 10 millimolar of sodium is about 230 milligrams. So on average, and I'll allude to this later, the average American diet consists of about 3,500 milligrams per day. So 230 milligrams would be sodium depleting. And then they would also take 3 doses of furosemide, which is a diuretic. And after that, the following morning, they would have another blood pressure measure. And so this would be sodium and volume depletion. All right, so this is representative data here. And so what we're looking at is blood pressure, the change in blood pressure from that initial blood pressure reading after the saline load, and then after the volume depletion. And so this is data that would be representative from individuals with normal blood pressure on the left and hypertension on the right. And so what you can appreciate is on average, individuals with hypertension would experience a greater increase in blood pressure with saline loading and a greater reduction with the volume depletion and sodium depletion. And so this protocol is still used today. There's a group at the Vanderbilt Medical Center that uses this a lot to do a fairly quick assessment of who has salt-sensitive blood pressure and to further phenotype them. And the reason it's important is because the change in blood pressure from saline versus the furosemide is correlated with short-term dietary changes in sodium. So in this particular study, Dr. Weinberger and colleagues looked at changes in blood pressure when participants or patients went from a 200 millimole sodium diet, so about 4,500 milligrams per day, to less than 15 millimole, so less than 350 milligrams. And you can see that there is a correlation. And so the reason that this is an important insight is we have data from over 500 patients that were followed up about 27 years. And you can look at the cumulative survival here on the y-axis. And if we look at patients who had normal blood pressure, indicated by R, and were sodium resistant, normal blood pressure indicated by N, and sodium resistant indicated by R, you can see relatively high survival compared to individuals who were normotensive and salt sensitive, or individuals who were hypertensive, or individuals who were both hypertensive and salt sensitive who had the least survival over the follow-up time. So we hear a lot about salt sensitive blood pressure, but until I joined a lab that was really focused on it, I really wasn't too sure why it was such an important thing to consider. But it is predictive of future hypertension, stroke, and mortality, as we can see here. So objectives for today's talk are to talk about cardiovascular disease and dietary salt and blood pressure at the population level, and then some of the blood pressure independent effects of sodium that are less appreciated, including the effects of sodium on vascular function and kidney function and health. And then lastly, we'll talk about some of the strategies that my lab's seeking to pursue in the future to counteract some of the negative effects of sodium, including dietary ketones and dietary fiber. So first off, starting with why do we care about salt and cardiovascular disease? We know that heart disease is the leading cause of death in the United States. We know that stroke is also one of the leading causes. So combined cardiovascular and cerebrovascular disease play an enormous public health role or public health toll. And then we know that some of the costs associated with these diseases include $422 billion in costs when you think about things such as hospital stays, medications, productivity loss from work, and so forth. In terms of hypertension, we know it's the leading modifiable risk factor for cardiovascular disease. It affects 1.3 billion people globally, and it causes 10 million deaths globally per year. And then in this graph, this is data from the USA, and we're looking at percent of the population with hypertension. And then we see age here on the x-axis. And so what we can appreciate is that there's an age-related increase in hypertension such that older individuals, over 80 to 90% of them have hypertension. And then we can also see that there are some sex differences with hypertension such that after the menopausal transition, female patients tend to have similar proportion of hypertension to male patients, whereas in the premenopausal years, males tend to have a higher proportion of hypertension. So in terms of salt and blood pressure, salt is one of the leading risk factors for increasing blood pressure at the population level. So this is data from the PURE study, tens of thousands of individuals across the world. And so what we're looking at here is urinary sodium excretion on the x-axis. So in general, the kidneys do a pretty good job at excreting sodium. If you eat more sodium, you then excrete more sodium. So we can use urinary sodium as a proxy for sodium intake. And so what we can appreciate here is that as we see an increase in urinary sodium excretion, we see an increase in systolic blood pressure here. And that's after adjusting for important confounders such as age, sex, BMI, geographic region, education. And so in terms of salt sensitivity, I provided that question earlier, and Dr. Weinberger and colleagues using their inpatient stay, they would define salt sensitive blood pressure as a change of blood pressure, mean blood pressure of greater than 10, 5 to 9 would be considered intermediate, and less than 5 would be considered salt resistant. Now in a lot of studies, including this consensus paper using data from GenSalt, most groups will use a change of mean blood pressure of 5 or greater is salt sensitive and less than is salt resistant. However, it is a continuum, and I wanted to use these graphs to kind of display that. So normally we kind of categorize people, but it is a continuum. So we can see percent of the population here on the y-axis and change in systolic blood pressure. And this is using data from GenSalt. So this is going from high salt to a low salt intervention. And so what we can see is that for most of the population, there's a subtle decrease and blood pressure anywhere from 2 to 4 to 6 millimeters of mercury. However, we do have extreme responders who will see a decrease anywhere from 10 to 20 millimeters of mercury when they adopt a low sodium diet compared to a high sodium diet. This data is essentially transposing the previous data, so going from a low salt to high salt intervention. You can see that for most individuals, there's a subtle increase in blood pressure. However, there are extreme responders whose blood pressure increases 10, 15, 20, even up to 30 millimeters of mercury. And for the sake of time, I won't go into this in too much detail, but this is basically the same sort of data, but with diastolic blood pressure. So in terms of salt-sensitive blood pressure, we know that context does matter. There are health disparities and different individuals are affected differently. So just as I pointed out earlier with the Weinberger protocol, individuals who have hypertension tend to experience a greater reduction in blood pressure with sodium restriction. And so this is data from the DASH sodium trial, which I'll explain a little bit more about in the next couple of slides. But what we can see from that is individuals who had hypertension experience a greater reduction in blood pressure when they go from high sodium to low sodium. It's well documented that African Americans tend to experience a greater reduction in blood pressure with sodium reduction or a greater increase with high sodium. That could be a whole talk in and of itself. So that's the focus of my K Award, is trying to elucidate some of the social determinants and health behaviors that might contribute to this. We know that older age is also associated with more salt-sensitive blood pressure. A lot of studies indicate that women tend to have a greater proportion of salt-sensitive blood pressure as well. Some of these data are confounded by studies that have given men and women the same sodium load, but in the real world, women tend to eat less calories or fewer calories and a lower absolute amount of sodium. So there's some noise in that data, but in this particular study, DASH, where there wasn't a statistically significant difference between men and women, there wasn't a significant difference. So there's some nuance there. And then these investigators also looked at BMI, which wasn't a significant factor. Okay, so the problem here, when we talk about salt-sensitive blood pressure and how sodium may affect blood pressure, is that about 90% of Americans overconsume sodium. So this is based on recommendations from the Dietary Guidelines for Americans, which sets the recommendation at 2,300 milligrams per day, and the American Heart Association, which sets that recommendation at 1,500 milligrams per day for optimal cardiovascular health, or individuals who are at increased risk. And then, as I pointed out earlier, we do know that there are sex differences in habitual sodium intake. So on average, it's about 3,000 milligrams for women, about 4,000 milligrams for men, taking out to an average of about 3,500 milligrams for the population. And so one of the questions is, why do we eat so much salt? And so we've talked about sodium reduction as a nation for years and years, but we struggle to do that as a population. And it's because sodium is so ubiquitous in our food supply. It's in all the processed foods. It's really hard to reduce your sodium content in your diet unless you're committed to making all your own foods essentially from scratch at home. So the AHA has this list of salty six, some of the main contributors of sodium in the diet. So breads and rolls, poultry, sandwiches, which contain multiple ingredients on this list. Pizza also contain multiple ingredients, condensed soup, and then cold cut meats. In fact, we know that about 10 foods make up 40% of our sodium intake. Processed foods make up 70%. Naturally occurring makes up 14%. And then only 5% is added at home with the salt shaker. So a lot of the messaging over the years has been, don't add salt to your food, which is really only a small source of sodium. And then I always like to provide some concrete examples here. And so we have Papa John's pizza. So this would specifically be 3 slices of pepperoni pizza would be 2,700 milligrams. So that would put you over the daily recommendation in that one meal. An Italian BMT from Subway is 1,100. A can of Campbell's chunky chicken noodle soup is 1,500 milligrams. And then a Chipotle steak burrito is 2,300 milligrams. So we know that the background diet plays a major role in affecting salt-sensitive blood pressure. And so other components in the diet that influence salt sensitivity that have been elucidated include fiber, dietary potassium, and dietary nitrate. And so one of the studies that's helped us realize this is the DASH sodium trial designed by Frank Sachs and colleagues in the 90s. The first seminal paper was published in 2001. And so the DASH diet stands for Dietary Approaches to Stop Hypertension. It's a diet that's high in vegetables, fruits, whole grains, low-fat dairy, fish, and poultry, as opposed to red meat, beans, nuts and seeds, and vegetable oils. And so this is some of the primary data from that trial. And so what we can look at or appreciate here is the control diet, which is always displayed on top here, and then the DASH diet, which is on the bottom. And then amongst these two different diets, the standard American diet and the DASH diet, participants were randomized to 4 weeks each of high sodium, intermediate sodium, and low sodium. And so what we can see here is that for any given level of sodium, the DASH diet resulted in a lower blood pressure compared to the control diet for both systolic and diastolic blood pressure. However, even on the DASH diet, there was an effective sodium reduction in terms of blood pressure lowering. All right, so moving away from just blood pressure, if we want to talk about vascular function or endothelial function, we'll talk about some of the data that's out there on sodium and endothelial function. So we know our blood vessels are composed of 3 layers: the endothelium, or the tunica intima, the muscular layer, or the tunica media, and then the outermost layer, the tunica adventitia. So we're mostly interested in endothelial function here. So normally when you experience an increase in shear stress throughout your blood vessels, the endothelium will release nitric oxide, which acts on the underlying smooth muscle, resulting in vasodilation. So one of the major techniques that we use to assess this is brachial artery flow-mediated dilation. So here we have an individual in the lab. You can see technician holding a probe so that they've imaged the brachial artery. And after you obtain a 1 or 2 minutes, depending on the lab, of baseline data, you inflate this cuff that's just distal to the elbow for 5 minutes to cause ischemia. And then after that 5-minute period of ischemia, you release the pressure in the cuff, which causes a reactive hyperemic response and should cause the endothelium to release nitric oxide and result in vasodilation. And so the reason that we care about this measure, so it depends on the study, it's 8 to 13%, but on average, most studies will show that for a 9% change, or for every 1% improvement in FMD, you'll experience a 9% reduction in cardiovascular risk. This is just kind of a closer view of what we may see in the lab. So your baseline image, we're looking at the vessel diameter and blood velocity using Doppler so that we can calculate blood flow and shear stress. And then this would be after that occlusion period. You can see that there's a much greater increase here in blood velocity or blood flow. So in terms of some of the data that's out there with salt and vascular function, this is data from my postdoc mentor's lab, Bill Farquhar. And so in these initial studies, they use 7-day diets. So for 7 days, there was a run-in diet where participants consumed a recommended sodium diet, and then they would be randomized to low sodium or high sodium. So low sodium is 500 milligrams per day, and in this case, high sodium was 7 grams per day. And so here we're looking at urinary sodium excretion. So as you would expect, going from a low sodium to high sodium diet, there's a very large increase in sodium excretion. And in these participants, you can see that 24-hour mean arterial pressure is essentially flat. So they would be classified as salt resistant, whereas if there was an increase here, they would be salt sensitive. So despite the fact that in this cohort, the individuals were salt resistant from a blood pressure perspective, we can see from the individual data that most of the participants experienced a reduction in endothelium-dependent dilation or flow-mediated dilation here. And then when we looked at the group average data, you can see that there's a significant reduction in flow-mediated dilation. All right, and so one of the things that we were interested in during my time as a postdoc in the lab was sodium and blood pressure responses during exercise. And so to do that, we used a controlled feeding trial where we were interested in measuring sympathetic outflow. And one of the caveats to microneurography, or the technique that you use to assess sympathetic outflow, is that you place electrode in someone's perineal nerve in their lower leg, so they can't move at all. And so my colleagues in the lab, including Dr. Babcock at the time, we were interested in blood pressure responses to exercise using dynamic exercise. So we started a new study using salt capsules to manipulate dietary sodium and increase people's salt intake. And we're interested in the potential relation between vascular function and blood pressure reactivity during exercise. And so the reason that we cared about blood pressure reactivity is there is prospective data where individuals who had normal blood pressure at baseline were categorized into quartiles of blood pressure responses during submaximal exercise. And so what we can see here is over average 7-year follow-up, individuals who had the greatest blood pressure response to exercise had the greatest cumulative hypertension incidence over follow-up. And then you can see as you go down in those quartiles, there's less incidence of hypertension. So this could be used as a potential tool to kind of screen individuals who might be at increased future risk if they take in high salt or some other sort of dietary stressor. If blood pressure during exercise is exaggerated, that might indicate that they have an increased risk for future hypertension under those given conditions. So for this particular study, as I mentioned, we used salt capsules. This was done in young, healthy adults who underwent screening. We did some fitness testing, and then they were randomized to either placebo, which was dextrose capsules, or sodium chloride capsules for 10 days each. And then whichever they didn't receive for that first intervention, they would receive that during the second period after at least the 2-week washout. And so similar to the controlled feeding studies that had been done in the lab, we did find that salt capsules or salt loading through salt capsules resulted in a reduction in flow-mediated dilation. And we also found that there was an increase in systolic blood pressure during submaximal dynamic lower body cycling exercise. And interestingly, we found that a change in FMD, so the worse that your vascular function was during the high salt loading, more likely you were to experience an increase in systolic blood pressure during the exercise bout. So to kind of summarize some of the data on salt and endothelial function, just for the sake of time, I just discussed those findings, but this is a figure from a review paper published by Dr. Jordan Paddock and colleagues about 3 years ago now. And there's been over 20 studies in human participants where they've manipulated sodium and measured endothelial function using different methods. And they found that sodium results, or short-term sodium results, in a decrease in vascular endothelial function. And some of the key mechanisms include an increase in the expression of pro-oxidative stress enzymes and a decrease in endogenous antioxidants such as superoxide dismutase. There's also been some work with high sodium resulting in degradation of the glycocalyx, which helps with mechanotransduction. So next I'll share some of our data on salt and kidney function. So for a bit of background, I've talked a lot about salt and cardiovascular disease, but we do know that high salt is associated with incident CKD over time as well. There's a number of purported mechanisms, including increased arterial stiffness, which could lead to increased pulsatility in the kidney. And then there's been growing interest over the past, I would say maybe 4 or 5 years on high salt leading to increases in kidney injury biomarkers that might be associated with future CKD. So the two that I'll focus on are neutrophil gelatinase associated lipocalin or NGAL and kidney injury marker 1 or KIM1. And so in terms of why we picked these particular biomarkers, there's some preclinical data, and then there's also data from Cardia and MESA indicating that these two particular biomarkers are associated with CKD development over time or the progression. So in terms of rodent data, this was data that was published in 2018 in Wistar Archaeota rats. And so here we're looking at different levels of sodium chloride. And so we can see that the very high sodium condition resulted in an increase in urinary NGAL within just 1 week. The caveat here would be that 8% sodium chloride would be a very high sodium diet in humans. And then one of the other things to point out in this particular study was that this change occurred before any sort of differences in urinary albumin. So this change in NGAL or kidney injury seemed to occur before any sort of proteinuria. And then this is data from Doug Seals and Kristen Nowak and colleagues that was published back in 2020 in older adults. So this was comparing habitual consumption of sodium to 5 weeks of modest dietary sodium restriction in older adults. One of the things I wanted to point out is they used a 24-hour sodium excretion. So that's good from a methodological consideration. 150 millimole per day for habitual. So that's pretty close to what I discussed earlier for the US habitual intake of about 3,500 milligrams. And they essentially cut that in half. So fairly modest sodium restriction. And in this particular study, they found a 31% reduction in urinary NGAL, and they couldn't detect KIM1 in their assay. So we sought to use the same study I mentioned earlier with salt capsules to do a similar study in healthy young adults. So again, this was a crossover study using placebo or sodium chloride. And then we measured a 24-hour sample in our study as well. We measured creatinine, creatinine clearance, cystatin C, urea, and then, as I mentioned, NGAL and KIM1 using assays. So this study was kind of a cool study for me because it happened during COVID. And so we kind of had to pivot some things, and it was my master's student's thesis project. So it was the first study from the lab. As I mentioned earlier, the study took place in young adults. So on average, they were in their mid-20s, normotensive, so a fairly healthy cohort. And I bring that up because some of our findings were somewhat surprising to us. So this is data from the placebo condition and salt condition. You can see that there was an increase in body mass, so that would suggest some level of sodium retention or volume retention. But again, these were young adults. They were on average salt resistant, so you can see no change in systolic, diastolic, or mean blood pressure. And as you would expect, a large increase in urine sodium excretion, and then an increase in plasma volume. So onto our key findings. When we measured plasma NGAL, so potential sources of extrarenal NGAL, there was no difference, which we didn't necessarily expect there would be. However, when we measured 24-hour NGAL index to flow rate, there was a significant increase. In our particular study, when we indexed these findings to creatinine, there was no difference, which I'll explain why that was in just a couple of slides. So for KIM1, same thing in the plasma, no difference. However, in contrast to NGAL, there's no difference in the urine KIM1 index to flow rate or index to creatinine. So in terms of why some of this data was a little surprising to us, so here we're looking at urine creatinine excretion on placebo and high salt. And so we found that there was an increase in creatinine excretion, no change in serum creatinine. So creatinine clearance was increased after short-term high salt. So this was just 10 days in healthy young adults. And so for our particular study, we classified a high GFR as 135 or higher. And this was somewhat surprising to us because there's been data before in patients with hypertension where short-term high salt led to an increase or hyperfiltration, but we didn't necessarily expect that in healthy young adults in just 10 days, which we did find. And then just as kind of a backup measure to support our creatinine data, we also measured cystatin C, as I mentioned, which was also elevated. There was no change in urea. And then again, just to kind of support that our sodium manipulation was effective, we also measured angiotensin II, which is normally suppressed with high salt, which it was, and then fractional excretion of sodium, which was also elevated. So the reason why we were kind of surprised with the glomerular hyperfiltration and kind of considering that a bad thing is there is some thought that over time glomerular hyperfiltration could lead to a future reduction in filtration in the development and progression of CKD. So this is data from hypertensive cohort where they looked at follow-up time here on the x-axis and cumulative proportion of individuals with a cardiovascular event. And you can see that both hyperfiltration and low filtration were associated with an increased risk of cardiovascular events over time, just kind of indicating some of that crosstalk that may occur between kidney disease and cardiovascular disease with sodium loading. So to summarize our salt and kidney data, again, we know that high salt is associated with future CKD from several cohort studies. We found an increase in glomerular filtration in just 10 days in healthy young adults. And we also found that NGAL was increased with short-term salt loading, supporting the older data or the data in older adults that was previously published. All right, so in terms of future directions that our lab is interested in, it's nutritional strategies to counteract high dietary salt. And so as I mentioned earlier, there are data suggesting that about 90% of our population overconsumes salt. It's very hard to do in terms of reducing sodium. So my wife is a dietitian. I've worked in labs that are interested in sodium. And if I will occasionally use like MyFitnessPal or something like that, just to kind of check in on my own diet, and it's really tough to reduce sodium. So even if you're otherwise trying to eat a healthy diet, like focus on fruits and vegetables and things like that, just various sauces are high in sodium, protein bars, it's just really hard to reduce your sodium content. So I've been really interested in strategies that might counteract some of the negative effects of salt that could maybe be added to the American diet a little more easier than necessarily reducing sodium intake at the individual level. So one of the metabolites that we've been focused on is beta-hydroxybutyrate. This is the primary ketone body, other than the acetoacetate. Normally, when we think about beta-hydroxybutyrate or ketone production, it's produced in the liver through ketogenesis, and this would normally occur in the context of things like a ketogenic diet, so a very low carb, high fat diet. If you're on a very low caloric diet or you're doing prolonged fasting, that can result in ketogenesis, or really long bouts of exercise could also result in an increase in hepatic production of BHB. And so then normally BHB is exported from the liver and enters the circulation where it could be used by extrahepatic sources as a source of fuel or a substrate. And so in 2018, a paper was published from Bina Zhou's lab at the University of Toledo, and it was on high salt and kidney fibrosis. And so in this particular study, we can see here on high salt in the red that there's an increase in blood pressure compared to low salt. That was true for systolic, diastolic, and mean blood pressure. And then they also did some histology to assess kidney fibrosis. And so one of the things that they also found in this study using metabolomics was that there was a suppression in BHB. So there were several metabolites that were decreased. 4 of them stuck out as being like very much decreased. And the main one was BHB. So this is from their mass spec data. And then they separately went back and performed assays specifically for beta hydroxybutyrate. And what you see here is under fasting conditions, there's a reduction in beta hydroxybutyrate with the high salt in red. And then under fed conditions, there was no difference, but this is essentially to be expected. So no matter what sodium levels in your diet, if you eat, there's going to be acute reduction in beta hydroxybutyrate. So the main thing that I was interested in here was that reduction in fasting BHB, and kind of wondering how exactly is salt affecting metabolism. And then they did further experiments to show that there's actually some relevance here with the BHB. It's not just some interesting finding that just happens to be there. So they restored BHB with a nutritional supplement for the rodents. It's 1,3-butanediol, and this essentially acts to force the liver to produce more BHB. And so we can see that here. Again, high salt is still red, but in this particular set of graphs, high salt and 1,3-butanediol is in purple. And so again, we know that the 1,3-BD is essentially forcing the liver to increase BHB. So under both fasting and fed conditions, there's increased circulating BHB. And compared to the high salt, we can see that there is a reduction in systolic blood pressure, diastolic blood pressure, and mean blood pressure. So that same group went on to do some work with vascular function. In this particular setup, we're looking at ex vivo resistance arteries from mice. And so here to interpret this data on the y-axis, you're looking at percent relaxation, and then we're looking at acetylcholine doses on the x-axis. So acetylcholine causes endothelial-dependent vasodilation. And so in this particular graph, we're looking at percent relaxation. So the lower this data goes, that means there's more vasorelaxation. And then when L-NAME, which is an inhibitor of nitric oxide synthase, or the primary enzyme that produces nitric oxide, is added, you can see that there's a significant blunting in endothelial-dependent dilation. So with high salt, we can see that there was a reduction in terms of the effects of L-NAME. So there's less nitric oxide-mediated vasodilation, and that was rescued with the addition of the 1,3-BD. So once you had more ketones on board, that seemed to restore nitric oxide-dependent vasodilation. And then there was also some interesting human data that came out a few years ago in patients with obesity. So one of the common findings in patients with obesity or who have impaired metabolic health is a reduction in flow-mediated dilation. And so in this particular study from John Little's group, we have placebo-controlled data, so there's no change after 2 weeks of placebo and FMD. However, in the patients who received a ketone monoester supplement, we can see that there was a significant increase in flow-mediated dilation. So that caused us a few years ago to decide, hey, this ketone data, this preclinical data looks very interesting. So we wanted to see, first off, was there any evidence of a suppression of BHB in human participants? So this is data that Matt and I actually started to collect several years ago now, but we basically pooled samples from some of the studies that were going on in the lab. So participants who had received a medium salt diet or a high salt diet, again for 10 days each. And we did note that there was a reduction in circulating BHB. So the caveat with this particular data was that this is mostly in male participants, so we don't know if there's any potential sex differences, and it's mostly healthy young adults. So the next step was, could we potentially use a ketone monoester? So this is a commercially available supplement that increases BHB over the course of about 2 hours. Could we give that the same way that John Little's group gave to patients with obesity to potentially counteract the effects of salt? And so this is a trial that we've been working on in the lab for a little over a year now. Similar to our previous salt capsule study, we have healthy young adults who come into the lab after 10 days each of placebo capsules in a placebo drink, salt capsules to increase their sodium intake in a placebo drink, and salt capsules in a ketone monoester drink. So two of my students, Braxton Linder and Sulim Jung, have been using this as part of their dissertation studies. And this is some of our really early preliminary data. Did an unblind at N=8. We have more data now, but we're still blinded to that. So in terms of this first measure that we're looking at, it's a change in blood pressure after an acute bout of exercise, so post-exercise hypotension, which is indicative of the potential blood pressure lowering effect of exercise over time. And we didn't see any evidence of a difference, but again, this is a really small sample size. However, with blood pressure reactivity, so similar to what we showed earlier from the salt capsule study, we do see at least some evidence with a moderate effect size in just 8 people that there's a greater increase in mean arterial pressure with dynamic exercise, which seems to be suppressed with the addition of the ketone monoester. We also have some data in terms of inflammatory cytokines. So these were measured in plasma after each of those dietary arms. So after each of them, we did a blood draw, we stimulated whole blood with LPS for 2 hours, and then we pulled off the plasma and ran inflammatory cytokines. And as of now, there does seem to be some promising data indicating that the high salt results in an increase in tumor necrosis factor alpha, which seems to also be blunted after the addition of the ketone monoester. This is just some of the data that we've been collecting for that study. We also have vascular endothelial function data from both the FMD technique that I mentioned, and then a lower limb assessment of endothelial function. So there's a lot more data to come, but this was just some preliminary data that I wanted to share since we have this analyzed. And then to take this study a step further, as I mentioned earlier, one of the things that affects salt-sensitive blood pressure or the adverse effects of salt is aging. So we just recently had an R21 funded where we're going to do a similar study, except in older adults, 60 to 85 years old. So very similar design, similar measures, but assessing individuals who are much older age who might experience a greater adverse effect from the high salt and potential improvement from the ketone drink. And then with just the last few slides, just sharing a bit of data on salt and fiber. So I do have a little bit of preliminary data to share, but it's all cross-sectional at this point. But the idea for this future study is to potentially leverage fiber similar to how we've used the ketones. So for this particular study, it would entail controlled feeding. We're submitting this as a USDA grant this week, and then hopefully as an R01. But individuals would receive a background diet that's low in sodium, and then placebo capsules and placebo salt capsules and placebo beverage, and then salt capsules and fiber in the form of resistant starch, which we can include. It's flavorless, so we can use it in water, or we could use it in muffins, things of that nature to increase fiber intake. So the idea behind that would be that increasing fiber would act on the gut microbiome to increase metabolites such as short-chain fatty acids, which have systemic effects that may influence blood pressure and vascular function and kidney function. So that's kind of the premise behind why we're specifically interested in fiber. And we know that it's one of the main components in the DASH diet that's been shown to be protective. So in terms of implementation potential, I actually think fiber is probably more exciting than the ketones. So the ketone monoester drinks are, going to be honest, they're quite disgusting. So we've tried to mask them for our participants, adding different sweeteners and things of that nature and flavors, but they're still pretty gross. But with fiber, we already know that there's a lot of products that are available today that are fairly high in fiber. So like Aloha bars, for example, have 10 grams of fiber each. And that's pretty substantial because at the population level, we consume about 15 grams per day. And we know that's well underneath the recommendation for both men and women. So for women, it's in the higher 20s, and men, it's in the 30s, and on average, we're eating 15. So a bar that contains 10 is a lot. This company, Lily's, makes gummy bears that have 27 grams of fiber in one serving. So working with our dietitian at IU, she's actually recommended if we were to use something like this, you'd probably want to ramp people up and not just give them 27 grams of fiber all at once. Benefiber and Metamucil have been around for years. Olipop is really popular amongst college students. So this has inulin, another source of fiber, and it's 9 grams per can. But I know a lot of like younger adults really like Olipop. And then things like Bonza are different brands of lentil or legume-based pastas. This is a chickpea pasta, but are also really high in fiber compared to standard pasta. So it's something that I think could be implemented at scale where we could add more fiber to different foods. So again, this data, caveat here is this is all cross-sectional data for all of our studies. We do some dietary intake, so 6 days of food and fluid records. And then from there, we're able to use software called NDSR to derive sodium and fiber and soluble fiber. And so with our cross-sectional data, we've looked at dietary sodium from this 6 cumulative days divided by fiber. So sodium indexed to fiber, and we've created tertiles here. And we've controlled for things such as magnesium, potassium, race, sex, and age. And we found that individuals who are in the highest tertile of sodium indexed to fiber have the highest systolic blood pressure. This is just resting data. That's also true of diastolic blood pressure. So this is all in-lab based. And then as I mentioned earlier, we've been interested in exercise blood pressure responses. So same thing here. Now we're just looking at correlations, but when we look at sodium index to total fiber, we can see that absolute diastolic blood pressure, or the change in blood pressure with hand grip exercise, seems to be higher with increased sodium index to fiber. And then to isolate the metabol reflex after squeezing exercise, we can inflate this cuff here right before the cessation of exercise to trap metabolites. That's a commonly used applied physiology technique. And we see the same thing where if we do a median split here, individuals in the higher sodium to fiber group have a higher blood pressure response. And so for the sake of time, I didn't blast in a ton of pilot data here, but we have some interesting data with metabolomics and short chain fatty acids as well. So that's what kind of led us to want to look at this data with an intervention. So that's what we were just submitting this week, and then hopefully submitting that for an R01 too for some controlled feeding with salt and fiber. So mainly wanted to thank my lab. I've had students working really hard for the past 4.5, 5 years that have helped collect a lot of the data here. My colleagues at Delaware, when I was a postdoc, we're still publishing together, still in touch. So they've helped collect a lot of this data, and then different funding mechanisms, and wanted to thank you all for your time today and take any questions you have.
Thank you so much, Dr. Austin. That was amazing. We'll open it up for questions from the audience. See a couple of hands up over here. We come to Dr. Christie first. Of course.
Yeah, appreciate it. Thank you so much. That was excellent. Question around the fiber. I'm a gastroenterologist, so I love fiber, but not too much of it.
Yeah.
So with the fiber intake, are you also looking at weight loss associated with that? Because as you know, fiber is going to decrease gastric emptying, increase early satiety, and then maybe some of this weight reduction or some of this blood pressure reduction is related to weight loss. So making that correlation. And then the other thing is, have you thought about prebiotics? Because there are prebiotics that also can increase beta hydroxybutyrate production and maybe have some of the similar effects.
Okay, cool. So for part one of that question, we kind of have some data. So our cross-sectional data, to support your speculation, a lot of the effects of the sodium index to fiber on blood pressure are mediated by BMI or waist to hip ratio. So we also find that those individuals tend to have higher central adiposity and higher BMI. So I think that's really interesting. And for the controlled feeding, because it's short term, one of the things that you mentioned is not too much fiber. So we're going to do like a dose escalation. So for the first week, we're going to give people 8 grams of fiber, then 16, and then 24, so that we kind of gradually increase that. So it will be 3 weeks of higher fiber. I don't suspect that we would see weight loss per se in just the 3 weeks, but AIM-3 is kind of more exploratory. And we're going to have like a ecological momentary assessment of appetite, just using like an app. And then in the lab, we'll do some appetite testing after the vascular and blood pressure testing. And then we have a mixed meal tolerance test. We'll look at the metabolic responses to that, and then some satiety measures after the mixed meal. So hopefully that could indicate what might happen in the longer term. And then the second question, I don't have an answer for. I didn't really look into prebiotics, but I definitely will. So that sounds interesting.
So thank you very much for presenting this, and it gave me 2 different questions. First, and one comment, which is that many of the changes that you're describing with salt are very similar to what we see with sugar. And so diabetes will and acute hyperglycemia will both lead to many of the endothelial things that you have described. But one of the things that's been quite distressing with youth onset type 2 diabetes is that we see this hyperfiltration early in disease that predicts the progression to diabetic kidney disease. And I wonder if epidemiologically it would be of interest or even possible to just look at EGFR and see if we can identify hyperfiltration such that we could figure out who we should be screening for that either premature hypertension or for further interrogation. So thoughts about that?
No, I think that's a great point. I think it was last year we did publish a review paper. It wasn't original data, but basically kind of discussing some of the links between sodium intake and metabolic syndrome and type 2 diabetes. And some of the literature that we did review was even in kids as young as like 2 years old from NHANES. I don't know that literature as well because all my work has always been in adults, but I definitely think there's literature out there in terms of sodium intake and weight gain over like very early, like toddlers and infants. So I do think that would be interesting. I don't know much about if anyone's done anything with EGFR and sodium intake in kids. I'd have to look into it.
And then did you have any thoughts, I'm sure you did, about what would be the mechanism whereby the ketones were lowering the blood pressure?
Yeah, so I know with the ketones, they act on GPCRs. So like, for example, GPCR 41 is expressed in the vasculature in the kidney. So that's been like one purported mechanism. One of my friends who does a lot of preclinical work, we've talked about potentially doing some experiments together because the data that's out there now suggests that there is some actions through potassium channels, and his interest is in like KIR 2.1 channels. So there could be some, I mean, as the data in rodents indicated, maybe some increase in nitric oxide bioavailability or acting through potassium-mediated vasodilation. But yeah, there's definitely a lot more work to do with the ketones and how they might even be influenced by salt, because that group is more of a cardiovascular group. So at this point, it's not even understood, like, are they acting, is like salt somehow influencing HMG-CoA or like the main enzyme that produces ketones? So it's not even clear how it's being suppressed. So there's definitely a lot of work to be done still.
Thank you so much for your talk. My question is, are there current studies on the utility of biomarkers, whether of the endothelial glycocalyx or otherwise, in predicting which patients are salt sensitive versus resistant?
To my knowledge, no. I think that's a great question. I just started at IU in January, so I'm kind of like making collaborations and stuff still, but given that our CRC has such a history in like these inpatient salt sensitivity studies, that's one thing that I think would be really interesting to look at in the future. Is it's tough because it's inpatient, but it's 3 days instead of here's 1 week or 2 weeks or 4 weeks of high salt and a similar period of low salt. So I think those would be cool studies to do in the future.
Thanks for a great talk. My question is also about the ketones, and I apologize if I missed this, but I gather your research is on is not on endogenously produced ketones, but is supplementing the diet with ketones. Is that correct? And then is there any data comparing the difference? Like, I mean, imagine a ketogenic diet has a lot of potentially confounding factors in it, but I mean, is there any data suggesting what the interplay would be? As a ketogenic diet, does that generate some of the same drops in blood pressure, et cetera, that you see?
Yeah, so I guess for the first part of the question, you bring up a good point, and that's something that I thought of as a limitation to our current studies. Even when I put in the R21, I was like, a reviewer, we'll just see what happens. A reviewer could kill me for this, but with the rodent studies, we see a suppression of endogenous ketone production, and we're not really addressing that. So we're giving a supplement that's going to transiently increase ketones 3 times per day, but we're not really getting at the source of the reduction in the ketones. So we'll see how the data continues to shake out, but something I thought about in the future was maybe trying to use a ketogenic diet where we get at that hepatic production of ketones rather than giving a supplement that increases it transiently multiple times per day. But then, like you said, we'd have to be really strategic about the ketogenic diet, because if we were to give like just a classical ketogenic diet, then we're causing huge differences in things that otherwise we wouldn't have had to think about, like saturated fat intake and things like that. And then it can be tricky too, just like with cheese and other things that are commonly used in the ketogenic diet, they're also high in sodium. So I know there's been some studies with like a more plant-based ketogenic diet. So I haven't thought that far ahead, but definitely something we'd have to be thoughtful about. Yeah.
Other questions? I have one for you, Dr. Robinson, and this has to do with your age-related study. My understanding is as we age, your vascular reactivity actually goes down, your arteries get more stiff. Mm-hmm. Is it then conceivable that you would be less salt sensitive the older you get, in the sense that you wouldn't actually have that much vasodilation or reactivity to salt? I guess I'm asking, what's your hypothesis for the aging study? What are you expecting to see?
Yeah, so this is data from Curtis Morris, a group that was at UCSF. They did a lot of work on racial disparities in salt-sensitive blood pressure, and some focused work specifically in African Americans because of the greater proportion of salt-sensitive blood pressure. So they would specifically try to recruit African American cohorts so that they could study salt-sensitive blood pressure. And they found that the number one predictor of salt-sensitive blood pressure would be an increase in renal vascular resistance and total peripheral resistance. So in terms of endothelial function, like if we were to use the FMD or some of the other techniques that you can use to assess endothelial function, I think to your point, there could be kind of a floor effect where if something's already reduced, can it be reduced much more, specifically to the vascular function? But it is documented that older adults tend to have more salt-sensitive blood pressure. So I think some of the effects on the kidney and total peripheral resistance are magnified.
Very interesting. Other questions from the audience? Maybe one last closing thought, and you touched on this, but so much of what I was thinking about Papa John's, which I'm never going to order again, thank you very much. But I was thinking about how much of this, the marketing of this, and how these foods are often marketed in ways that appeal to certain populations in particular. You and I talked about this earlier today in terms of the social determinants of health aspect of your research. I wonder if you could just comment on that with respect to kind of how we think about food and how that plays out when you think about food deserts, access to fast food, for example, and some of those other social determinants.
Yeah, I mean, honestly, I think it's huge. So as I very briefly mentioned, didn't want to get too much into the racial disparities component of sodium because I felt like that could be like half of a talk in itself. But again, the same group who's elucidated a lot of the effects of salt-sensitive blood pressure at UCSF with the racial disparities, they have findings where if you give African-American adults high potassium in addition to high sodium, that seems to attenuate a lot of the differences or the race differences in salt-sensitive blood pressure. And even within our own cohorts, we see large differences in fiber intake, potassium intake, hydration. So I think a lot of the foods that could maybe counteract the effects of salt are not as available to people who are in lower socioeconomic positions. So we know that across like different income distributions, a lot of us eat more salt than we should. But again, the background diet is so important. I think that that is really something that influences some of the differences in salt sensitive blood pressure. Just access to like fresh fruits and vegetables, and like with the hydration work, a lot of that has to do with like mistrust of municipal water. So I definitely think the social determinants play a huge role that are only more recently starting to be appreciated.
Great. Dr. Robinson, thank you so much for a fantastic Grand Rounds.
Thank you.